Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It is September 18th, 2025, and today we are talking about the Alascca study, which was published in this week's edition of the New England Journal of Medicine. And if you are an educator, an avid slide deck creator, I'll also point out there was a nice review on tumor lysis syndrome published in this edition. So if you're looking for good images for fair use in educational materials, I suggest you check that out. All right, so Alascca. This is Adjuvant Low-doseASpirin for colorectal cancer. This is a study that was, I think, presented in January, sometime around there, at ASCO GI, and then in the April update to the colon cancer guidelines, at least. I didn't check the rectal cancer guidelines. Adjuvant aspirin is listed as an option for PI3 kinase altered colorectal cancer. So let's get into the Alascca study, because this has changed the treatment algorithm. It is listed, adjuvant aspirin, low-dose aspirin is listed, recommended. So let's look at this study, which has been published now for the first time. Like I said, has been presented as an abstract. So the title of this is Low-dose aspirin for PI3 kinase altered localized colorectal cancer. That's where Alascca comes from, is the adjuvant. We have known for a long time that COX-2, which creates prostaglandin E2, which then stimulates the PI3 kinase pathway, which is one of the mother pathways for driving cell signaling and cell survival, differentiation, and cancer progression. We know that upregulation of COX-2 is implicated in some of these cancers. And so COX inhibitors, including low-dose aspirin, have been studied a lot of observational studies suggesting people taking NSAIDs or aspirin had a lower risk of colon cancer. There is a U.S. Preventive Task Force recommendation that low-dose aspirin can, if you look at a composite endpoint of preventing colon cancer and MI, has benefit. There's a long history of study in this area. In fact, one of the studies that led to our knowledge that COX-2 inhibitors have some cardiovascular detriment was a study of high-dose celecoxib for patients at a high risk of colon cancer for colon cancer prevention. I believe they had adenopolyposis, that APC gene mutation. I think that's what it was. So this is a study specifically looking at low-dose aspirin, 160 milligrams adjuvant for 3 years, or placebo in patients that had PI3 kinase altered colorectal cancer. Now, this is a study. These patients were 18 to 80, stage 2 or 3 colon cancer, or stage 1, 2, or 3 rectal cancer. All of these patients were from Scandinavia. They were the Norway, Sweden, Denmark, or Finland. This was sponsored by a Swedish government group. Pfizer provided the aspirin for this study. So thanks to them for the aspirin. 160 milligrams adjuvant for 3 years. They had two different kind of cohorts or different groups of people they looked at. They had this group A alterations were exon 9 and I think exon 20 hotspot mutations in PI3 kinase, and then they had group B, which were some other variants in PIK3CA, PIK3R1, and PTEN. And the primary endpoint, they didn't do any fancy alpha splitting like the pharma companies do. Their primary endpoint was colon cancer recurrence in that alteration A, which were exon 9, exon 20 mutations in PIK3CA. So very specific subset. But they did enroll, they looked at 13,000 patients. Half of those, about 6,400 were assessed for eligibility. You ended up with 500 patients with Group A alterations, 588 with Group B. And Group A were the primary endpoint here. And at the end of the day, you get about 157 in Group A randomized to aspirin, 157 randomized to placebo, and about the same numbers with the Group B alterations, and those results are submitted separately. So this is a relatively small study. We're talking about 600 people total, about 300 getting aspirin, 300 getting placebo. These patients' median age is 65, kind of fits. Most of these patients were colon cancer. About 110 in each arm had colon cancer. About 47 or 57 each arm had rectal cancer. So it's about 2/3 colon cancer, 1/3 rectal cancer, if we think of it that way. The one thing that is that I found striking looking at the baseline demographics is that the colon cancer subgroup, the patients with colon cancer, there's all stage 2 or 3 colon cancer. The number of people who did not receive any adjuvant chemotherapy was above 50%. And so you have, in the colon cancer, you have 45% of people that have stage 3 colon cancer. So it looks like probably almost all of them got adjuvant treatment. Only 28% got fluoropyrimidine plus oxaliplatin, and maybe some of these patients were over the age of 70, and so they would not maybe get that benefit from oxaliplatin. But even just single-agent fluorouracil or capecitabine only happened in less than 20% of patients, which means a lot of these grade 2 patients or stage 2 patients with colon cancer were not getting adjuvant treatment. Maybe that's reasonable based on their performance status, but that may also be kind of the standard practice in Scandinavia is more observation versus fluoropyrimidine, and we maybe are a little bit more aggressive here in the States. That I do not know. But that is one thing that is notable. Another thing to point out here is north of 20% of these patients are MSI high. If I were to go back and review this study in 5 years, we would say these patients should be getting probably adjuvant immune checkpoint inhibitors. We do know that now with Atomic study, the benefit of atezolizumab in those stage 3 patients with colon cancer. So we have a small study, 150 and 150 in Group A and Group B getting aspirin. It's in Scandinavia. They don't seem to be getting as aggressive adjuvant chemotherapy as maybe we would do here in the United States. And we do see in our primary endpoint, which is colorectal cancer recurrence, in those Group A alterations, exon 9, exon 20, PI3 kinase mutations, a 3-year cumulative incidence of cancer recurrence, 14% with placebo, 7.7% with aspirin. That's a sizable effect size, and that's a hazard ratio of 0.49. And that 95% confidence interval is 0.24 to 0.98, p-value 0.04. Statistically significant. Would be clinically significant if those results were extrapolated to the entire colorectal cancer population. If you look at the Group B alterations, the benefit appears to be of the same magnitude, potentially even larger. We do have no formal testing, so these are nominal p-values and hazard ratios, which I think when statisticians say nominal, they mean meaningless. Hazard ratio 0.42, 95% confidence interval 0.21 to 0.83. So both of these hazard ratios are less than 0.5, large effect size. Both 95% confidence intervals for the Group A and Group B alterations are very wide, 0.2 to 0.8. That's very wide. This is very small patient subset in a very geographically limited and maybe ethnically homogeneous patient population. Subgroup analyses, you already have a small study. You're looking at smaller subsets. Probably not even worth exploring. Now, this has been added as a recommended option. I don't think it's not a category 1, but it's something to consider in those patients with stage 1, 2, or 3 rectal cancer. Or stage 2 and 3 colon cancer, that if they have an alteration in the PI3 kinase pathway, you could do adjuvant aspirin for 3 years. Side effect-wise, we see hematologic disorders and 15% on aspirin and 9% of people on placebo. I get maybe that's anemia. They don't actually, they don't report a ton of bleeding. They kind of report them case by case. So doesn't seem to be that there's a lot of extra toxicity from low-dose aspirin. 160 milligrams you wouldn't think would be that tough. In the States, we'd have to do 162 with our 81 milligram baby aspirin dosage form that is available. So something that, if you're familiar with the book Moneyball or the movie Moneyball, looking for the whole premise of Moneyball in baseball is try to find the undervalued asset that is effective and has value, but it's cheap. And this would be like a Moneyball approach to improving our cure rates potentially with colon cancer. Aspirin is cheap, widely available. We give it to kids, for crying out loud, the baby aspirin. Okay? Now, and it seems safe, seems relatively safe. Now, that being said, this is the type of study that seems if we had a larger study in a wider patient population that was, say, 500 people, I would not be surprised if we did not see confirmation of benefit. Okay, and that is one of the what should be one of the tenets of evidence-based medicine is confirmation of these findings, especially if the findings are from a small study like they are, or from say a very specific patient population. And this is a pretty specific patient population in Scandinavia. So, I would like to see more study confirming this. And what adds to the bioplausibility of this is we do have lots of observational studies supporting this use of NSAIDs. This is more targeted. It's a biomarker-driven approach in those that are PIK3CA mutated in exon 9 and exon 20. So it is something to be aware of. It's something to be thinking about, especially if you have a patient that has this mutation and they're not a candidate for adjuvant chemotherapy. You really feel good about doing this. And probably based on the guidelines here, should be offered those folks who also receive adjuvant chemotherapy or total neoadjuvant therapy for rectal cancer, neoadjuvant therapy for rectal cancer. I've kind of been looking at this through a colon cancer lens, but these results, include both, a third of these patients had rectal cancer and 2/3 had colon cancer. But this is the Alascca study. It's been incorporated into our guidelines and something we should be thinking about. So if your practice is not doing PI3K testing on your early stage colorectal cancer patients and just on metastatic disease or just those with metastatic disease, is probably an approach that needs to be rethought locally at your center. So that is the Alascca study. Thank you for listening, and you can follow me on X, at PharmDeetNib, and on other social media platforms at UnclePharmPod. And until I talk to you again, remember, doses matter.